Hello and very warm welcome to this public event that is organised by Dementias Platform UK. Today's topic is frontotemporal dementia, and we have two fantastic talks by two very prominent experts in the field. These are Dr. Siân Thompson, who's a consultant neurologist we work together at Oxford University Hospitals. Siân has done a PhD in frontotemporal dementia with one of the most preeminent thinkers in frontotemporal dementia, Professor Hodges. We also have Professor James Rowe, who's a professor at Cambridge, again, a consultant neurologist. He is an expert in cognitive disorders and leads a very broad program in a number of cognitive disorders, but has a particular focus on frontotemporal dementia. So we're looking forward to two great talks from two expert clinicians and expert researchers in the field. But before we get on to this, just to reiterate the background of who we are and why we're doing it, this is a public event organized by Great Minds. Great Minds is a research register that you would be part of, and it's a research register specifically created to accelerate brain health studies and to accelerate treatments for dementia. The reason why this is needed is because we now know that dementia starts up to 15-20 years before first symptoms, and data going back a number of years can be invaluable in actually finding out who is most at risk. And that's why Great Minds is offered to people who would have contributed to other studies over the years and are happy to be contacted on the basis of their medical data. So if you are thinking about joining Great Minds, then you can register on our website. You can find us easily online if you Google Great Minds. And if you're not part of a cohort, then you can do that. You can join by first joining Dementia Research, and then they'll give you the link to Great Minds. We've had an amazing group of studies who have contributed to this effort, and you can see where people who signed up are located in the UK. And in the past couple of months, we've gone over 5,000 people, which I think we can all agree is a fantastic result. So without further ado, I'd like to yield the floor to my colleague, Dr. Thompson, who's going to talk to us about the way that frontotemporal dementia presents clinically. Thank you very much.
Okay, good evening, everyone. I'm Siân Thompson, as Ivan introduced, and I'm a clinician primarily, working in the Cognitive Disorders Clinic in Oxford. So I'm going to give this talk primarily from the view of a clinician, and I hope to cover a number of areas. So first of all, what is frontotemporal dementia and who does it affect? I'm going to talk a little bit about why this is a condition that is difficult to diagnose, and touch briefly on the pathology and genetics. I'm going to talk a little bit about what tools are available for us to use in the clinic and why we need to get better at doing this. So, first of all, frontotemporal dementia is a devastating disease, not only for the individuals who suffer with the condition, but also for the families of those individuals. It's a disease that affects a number of different components of behavior and personality, as well as eroding language, executive control, and may present with a number of quite physical symptoms, such as early falls. But this is a disease that many people will not have even heard of. It's not that it's a new disease. In fact, it was described more than 100 years ago by Pick. And you can see here when he first of all described a patient with progressive language problems. And you can see here some of the typical changes within the brain that were described 20 years later by Alzheimer on those first cases. And the picture in the bottom left corner shows the typical changes described in the brains of these individuals, with shrinkage or atrophy affecting mainly the frontal areas and the temporal areas of the brain. So, is this a rare disease? Is that why many people will not have heard of it? Well, it is rare when we consider it against other degenerative diseases such as Alzheimer's. The lifetime risk of developing frontotemporal dementia is in the region of 1 in 700, whereas a woman of 65 years old would have a lifetime risk of perhaps closer to 1 in 8 of developing Alzheimer's. However, in the clinical setting that I work in, where I see patients who present with symptoms in general before the age of 65, this probably is one of the commonest forms of dementia that we see. So we know that this condition is difficult to diagnose. On average, it can take more than 2 years to make a diagnosis from symptom onset. And in those patients that present with predominantly changes in their behavior or personality, it often takes up to 4 years or even longer to make a diagnosis. One of the reasons for this is that the symptoms of this disease overlap significantly with other conditions. So, for example, about 50% of individuals who present with the behavioral variant of this condition will first acquire a primary psychiatric diagnosis of a non-degenerative condition. But the symptoms also overlap with other dementias, so that individuals presenting at an older age may be diagnosed with Alzheimer's disease, and patients who present with more physical symptoms may first of all be seen in a movement disorder clinic. The other reason why this is difficult to diagnose is that we do rely very heavily on our clinical assessment of these patients. And that's because the tools or the diagnostic tests that we have are not particularly sensitive. And I'll touch on that again a bit later on. So frontotemporal dementia is actually a spectrum of quite different disorders, which I will talk about. I'm going to focus just on the 3 core disorders, and those are the behavioral variant, individuals presenting with those changes in behavior and personality, and also progressive language impairments, both non-fluent, that's the non-fluent variant of primary progressive aphasia as it's known, or the semantic or fluent variant, PPA. There are a number of other very important related disorders, however, which often present with more physical symptoms, such as those individuals presenting with frontotemporal dementia with motor neurone disease, or with disorders of eye movement and early falls, patients with progressive supranuclear gaze palsy. I'm not going to return to this second group, however, during the talk, but I'm going to focus primarily on the first group. So to give you an idea of how these patients present, I'm going to give 3 brief case histories of patients that have been seen in our clinic in Oxford to illustrate some of the main features and also some of the diagnostic difficulties. So this first patient I'm going to present was 58 years old at the time of presentation, and he was actually already an inpatient on a psychiatric unit, having taken an impulsive overdose at that time. He'd also had a brief admission within the preceding 6 months for depression. But when the history was further explored, probably symptoms went back at least 3 years, but these were subtle at onset, including just some withdrawal from social situations, a loss of interest in going out for dinner and meeting friends, which was unusual, and also showing slightly greater rigidity in terms of the daily structure, wanting to have food in the evening at a very specific time, even if that was at the expense of missing other activities. He'd not responded in quite the normal way from the family's point of view to some recent bereavements in the family, and hadn't really shown interest in the response of others to those emotional events. But none of these symptoms had added up to enough for the individual or their family to go to the GP. It was only really in the year before he presented with the overdose that his behaviour had become more unusual and had raised alarms. He developed a very sweet tooth and had gained 3 to 4 stone in weight. Another feature that we commonly see is that he developed some unusual compulsive or ritualistic behaviours. He was hoarding tissue boxes and razor blades, and there'd been a decline in his personal hygiene. There was also, when explored, a possible family history in a paternal uncle and also first cousin. When he was seen at this time, he was very cooperative with the examination. He didn't show much insight into the difficulties that he presented with, but he had a normal physical examination. He did have some assessment of his memory and thinking in the clinic. This showed some mild difficulties, for example, with being able to produce a certain number of words in a minute on a certain category, and also some slight difficulties with naming. However, his initial investigations were unhelpful. He had a structural MRI scan of the brain, which is conventionally one of our first investigations we would use after our clinic assessment, but this was reported as being normal. He went on and had a metabolic brain scan, a scan that looks at how the brain is using glucose, but this showed some non-specific changes and certainly no obvious changes in the frontal or temporal lobes, which would make one immediately consider a frontotemporal dementia. It was only some time later that the results of genetic testing came back, positive for one of the known causative mutations of behavioural variant frontotemporal dementia. From the story here, which is a fairly typical presentation we might see in clinic, I think the features to particularly bring out are the slow, gradual change in behaviour and personality, initially troubling, but not enough to seek help. And also the fact that these investigations, the initial imaging investigations, were not diagnostically useful. I'm going to turn now to one of the different syndromes that we come across, which is one of the language syndromes. So I'm going to present a case of a 66-year-old man who presented to clinic with a 2-year history of progressive problems with finding the words that he wanted. Initially, this had been fairly uncommon words or low-frequency words, but over time, even the words for more common objects had become difficult. However, he was otherwise doing everything as normal, no other cognitive complaints at all, and he felt that his understanding was normal. He performed quite well on the assessments in clinic. He did have some problems with, again, this ability to produce words in a certain amount of time, but otherwise no major changes, and his physical examination was normal. In this man's case, however, his initial brain scan, which is shown in the top left image, was abnormal. What you can see here is there's quite marked asymmetry on the scan, with the left temporal lobe being quite atrophied or showing shrinkage compared to the right, although the initial report was that this might represent changes of Alzheimer's disease or indeed frontotemporal dementia. At follow-up, he showed other typical changes, and that being primarily that his comprehension of single words had deteriorated. So in the clinic setting, when speaking about behaviour, he asked, "What's that?" I'm going to play a very short audio clip now, just to illustrate some of these points.
How's your comprehension? What's that? Understanding of words. Do you understand what people say to you?
Well, what you now said, no. The big thrill of mine is certain music.
Right.
And I listen to that a lot.
Maybe I could ask you to repeat a few words for me and tell me what they mean. Can you try that?
What's that?
Well, if I say a word, then you say it. And like violin, can you say that?
Yeah, violin.
What is a violin? Any idea what that might be? No idea on that one.
No, sorry.
Can you say the word caterpillar for me?
Caterpillar.
What would that be?
Caterpillar. Sounds like a cat.
Right. Any idea what this is?
He's holding up a stethoscope at this point.
Have you seen one before?
Don't recognise it.
No. Can we just hold it up so I can get it on?
Okay, so that short audio clip just demonstrated a couple of things there which are important, in that, as you can see, his speech was fluent. He was able to repeat words. The word sounds were all normal. He clearly had some difficulty with comprehension of single words. And towards the end of the clip there, he was being shown and then handed an object, which was a stethoscope. And what we do note as the disease progresses is that it's not only the understanding of individual words that becomes problematic, but also then the knowledge of objects in general. So being handed an object, not knowing how to use it or what it is. This condition tends to be very slowly progressive over years and has the longest prognosis of any of this group of disorders. Often people having a mean from diagnosis of 9 years survival. The typical changes in the scan are of quite marked atrophy in the temporal lobes rather than the frontal lobes. But as the disease progresses, the frontal lobes do become involved and behavioural changes typically occur. The final case I'm going to present briefly is of the non-fluent variant. And in this case, I'm going to present a 69-year-old woman, so of a slightly older age, which is typical for this condition, who presented with a 3-year history of gradually progressive problems with her speech. Although she did have some word-finding problems, this wasn't the main issue for her, but her speech had become slow and effortful. She didn't have problems with any other cognitive domains, and her comprehension in particular was very good. Complicating the picture is she'd had a left-sided benign brain tumour resected a year before, and it was initially felt that this might be responsible for the language problems that she was experiencing, although actually they didn't improve following the resection and in fact progressed. Just to illustrate the speech problems in this condition, I'm going to again just play a very short clip here. You will hear a name mentioned. It's not that of the patient, but of a speech and language therapist.
I am worse, constantly speech. And Tracy Phillips had interesting strategies, and I followed them, but it's slowing my speech. I am worse.
So as you may have been able to hear there, the speech obviously was slow, and often what we hear is that the individual word sounds may be slightly distorted. The other thing that as the disease progresses is that grammatical errors can creep in, and there's a general loss of intonation in speech. In this woman, she performed very well on cognitive testing in clinic and in more detailed neuropsychology. And her initial PET scan was not diagnostic. So it was really only with clinical follow-up that a diagnosis was finally reached. when her speech problems continued to progress over time. And sadly, as is generally the case in this condition, over time she became non-verbal. Also, she did develop some other physical features which can occur late in the course of this illness. So I hope there that I've demonstrated a little bit of the clinical variability of frontotemporal dementia. I'm very briefly going to touch on the genetics and pathology now. Unlike Alzheimer's disease, family history or strong family history is found in up to 30% of individuals with frontotemporal dementia. And in contrast to Alzheimer's disease, where less than 1% of individuals will have a causative gene mutation, in this condition, a causative gene is found to account for a lot of that heritability. And there are three main genes that we find: tau, the chromosome 9 open reading frame, and progranulin. In terms of the clinical syndrome and the genetics underlying that, the most common phenotype or the most common presentation we see in those with genetic frontotemporal dementia is the behavioral variant frontotemporal dementia. And in fact, individuals who have a combination of frontotemporal dementia with motor neurone disease are found to be the most heritable. When one looks at the pathology, the picture becomes even more complex, and we don't need to look at the details of this slide, except to say that if you look at the clinical syndromes, such as on the far left, the behavioral variant frontotemporal dementia, the underlying pathology, what we find within the brain of these individuals, can vary very greatly. In fact, the mapping of a clinical syndrome onto pathology is highly varied, aside from really in one of these syndromes, in particular the semantic variant, primary progressive aphasia, where we do tend to find a single pathological type. So I hope that from those case discussions, you can see that early diagnosis is challenging. As I've said, we rely heavily on our clinical assessment, and that's partly because our current diagnostic tools lack a degree of sensitivity. In the top right, you can see some structural MRI imaging, but we know that in 70% of the behavioral variant frontotemporal dementia, we only see a sensitivity of about 70%. We can use metabolic scans, the FDG PET scan, to look at areas of reduced metabolism in the brain, and this does give greater sensitivity than the structural imaging. But we can also see non-specific changes in primary psychiatric disorders. We obviously use other cognitive tests, detailed neuropsychology, and we can use behavioral scales as well. But again, there are overlaps with other diseases and syndromes. Needless to say, being unable or failing to make an early or an accurate diagnosis in these individuals, it has a huge impact on the individual and also their family. The diagnosis of a degenerative disease such as frontotemporal dementia, of course, is very different to having a primary psychiatric diagnosis. The management is different, and the education, the prognosis, the counselling for the family varies. At the present time, we have only very limited treatment strategies for patients with frontotemporal dementia. But in the future, we hope that we will be able to engage, and we are already in treatment trials. And this again is reliant on being able to provide these accurate early diagnoses. So essentially, there is a lot more work to be done. If we can improve our understanding of these complicated clinical, pathological, genetic relationships, we can go on to develop new diagnostic tools using biomarkers, using markers in blood and cerebrospinal fluid to make an early and an accurate diagnosis. This can lead on also to developing new treatments, both symptomatic, but also importantly, disease-changing treatments. so that early intervention will alter the pathway of diagnosis and quality of life for patients and their families, improve our symptom management, and importantly, of course, ultimately change the course of this disease. To summarize, frontotemporal dementia is a devastating illness. It often affects younger people, and the clinical presentation, as well as the genetics and the pathology, is highly variable. At the present time, the diagnostic tools we have available to us in clinic are quite limited, and the diagnosis is therefore often delayed. There is a great need for new diagnostic tests, for symptomatic, and most importantly, for disease-modifying treatments. And I'm going to end there.
Thank you very much, Sean. That's a great talk, very clear. And as you can imagine, it's led to quite a few questions. So we've got about 10 minutes to try and go through them, but we'll have a recap at the end where we can go back to any other things that have come up. The first question that we had was about the pathology that's causing this. So the question was whether amyloid is responsible. So what's known about the pathology that underlies it? I know James will speak quite a bit about this, but
yeah. So just briefly, I mean, so we do see amyloid or Alzheimer type pathology occasionally in patients presenting with a behavioral picture, but that's actually unusual. Most of these patients have underlying different pathologies. They largely fall into two main groups, although there are other rarer types, either the tau pathology or what we call the TDP43 pathologies. There is some mapping of the genetics onto the pathology. So, for example, the most common gene mutation we see, which is the one that's referred to as the C9orf72, does tend to cause quite a specific pathology. We see one of the TDP we call pathologies, which in itself is divided into a number of different groups. So I'm not going to talk in more detail, but essentially we do see very different pathologies in these conditions in general to the Alzheimer type pathology, although there is some overlap in symptoms. Yeah,
and there was also a question about the heritability. So I guess, you mentioned that some of these conditions are more heritable than others. So perhaps it'll be good to hear a bit more. And if I can extend the question, is there anything that, are there particular types of individual that are more likely to develop frontotemporal dementia? So we know, for example, that impulsivity varies between people in the normal population. How does that translate into frontotemporal dementia risk?
So so to talk a little bit more, I mean, when we talk about the heritability of this condition, so as I said, about 30% of individuals with frontotemporal dementia will have what we consider to be a very strong family history, suggesting strong heritability. And in that group, there are these three main genes, although there are rarer gene mutations that are also described. So in terms of I don't know whether in terms of the sort of clinical presentation, we know that, for example, one of the commonest mutation that we identify, which is this C9orf72, we can look further in the family history and we may find, for example, there's an increased likelihood of not only degenerative dementias in the family, but otherwise also other psychiatric disorders. The patients with genetic disorders or who carry one of these gene mutations tend to present with a behavioral variant, frontotemporal dementia, rather than the language disorders that I was talking about, although that's, again, it doesn't map on 100%. I don't know if that's answered the question or.
I think it did, yeah. And then there's a two, if you like, a different domain of questions about what can people do to reduce their risk. So there's a question whether mental stimulation can make a difference, or perhaps any dietary advice? What is the current consensus on this?
Yeah, so I think in terms of the evidence, as with any of the degenerative dementias, is that both, which may seem odd, but both physical activity, certainly, and also intellectual stimulation are both important in terms of cognitive health going forwards. Not specifically sort of brain training type exercises. It's more looking at other ways of stimulating, as one gets older, remaining sort of stimulated cognitively rather than doing any very specific tasks.
Thank you, Siân. And there's a question about who actually looks after people with frontotemporal dementia. So, as you know, there is this perhaps artificial separation in this country between mental health and if you like, physical health. So, Gregory had a question. Once you're diagnosed in the community mental health team and then get discharged, what does that tell you? Ultimately, you're given a diagnosis which is of a degenerative, ultimately progressive condition, and yet you're going to be seen by the GP. Who looks after people with frontotemporal dementia?
So I think it's not exclusively either psychiatrists, neurologists, or general practice. I think it differs from probably in different regions of the country and different practices. But I think what the evidence has shown is it's probably actually done best with a combination of different specialities being involved. So I think that, both neurology and psychiatry, and of course the role of the general practitioner, are all important. And certainly going through that early diagnostic process, there's very good evidence and standards have been sort of recently published, which suggests that certainly having both a psychiatric assessment and a neurological assessment contributes significantly to being able to reach a diagnosis earlier rather than later. And
David pressed us on the dietary aspects. Is there anything we can suggest about the type of diet that may or may not be helpful?
Do you mean sort of protective?
I think that's the sense, yes. Whether there's any evidence, how, for example, in Alzheimer's disease, there is a piece of research around Mediterranean diet. Has anything similar been developed for FTD?
Not to my knowledge. James may have something to add to this, but I'm not aware of anything that's specific in the frontotemporal dementia domain.
You want to jump in on this, James?
Anything that's good for your general brain health will help you with respect to your FTD. The most important dietary thing is to keep your alcohol down. Other than that, have a varied, standard, balanced, healthy diet. If perhaps a more Mediterranean diet twist to it is probably likely to help, but alcohol will be the main thing in your diet to reduce that, and that will help protect your brain and its resilience to FTD if that's at risk.
That's great. I know that we've got a couple more questions, but I'm keen that we stick on time. So Siân, fantastic talk. Thank you very much. So if you have time, do stick around, and we're going to have another round of sort of open-ended questions at the end. But I'll understand if you have to go. Next up, we have James. As I said, James Professor Rowe is a professor of neurology at the University of Cambridge. He leads a very diverse program of looking at the diagnosis, but also treatment of cognitive disorders. And he has a particular expertise in frontotemporal dementia. So it's a real pleasure to hear from him as well. Thank you, James.
So thank you, Ivan, and thank you to Siân Thompson for such a fantastic introduction to the subject. I have no disclosures that are relevant to what I'm going to talk about today, but they're there for the record. I'm just going to go back and revisit Arnold Pick's description of this illness, partly because the illness was known as Pick's disease for many years, but then over the last 20 years, it's really accrued many different types of name, and any of you who might be affected by this in your families might have had any one of these different diagnostic labels, and they all essentially refer to different forms of frontotemporal dementia, but this complexity in the naming and understanding of the different subtypes has I really think held back research and progress in FTD. But it's worth then going back to the original descriptions and thinking about what do people actually have, never mind the label, what do people actually have? And Arnold Pick's original description is extremely clear and relevant to any patient today. So it's progressive cognitive impairment and bouts of aggressiveness, not necessarily aggression, but the intermittent nature of the illness can certainly be common still. There was no disturbance of movement, so this is not a form of paralysis, but he had marked aphasia, the medical word for a loss of language, and he emphasized it was the understanding of speech that was substantially disturbed. He could understand simple things, and I think you had a sense of that in the clip that Dr. Thompson played with the man talking seemingly fluently until he was put on the spot to just ask about what was understanding or what was a violin. Some things just couldn't understand at all, said Arnold Pick of his original case. And the patient was over-talkative, suggesting a mild disinhibition. So this is a sort of pattern of problems that we would recognize today. One of the other aspects, perhaps to emphasize with frontotemporal dementia, is it can be very striking with its young onset. It's often thought of as a young onset dementia. It's the commonest form of dementia in people under 60. You may have read in the Daily Mail about this family who went public with their life with FTD developing as young as 30. If you follow Hollyoaks at the moment, you'll be aware there's an FTD storyline in Hollyoaks. But the average age of onset is in the late 60s. They're still younger than many other forms of dementia, but we do see a wide range of ages of onset. So in this little chart here, we've just plotted how common the illness is over the age range that's from 45 to 95. And you can see, although the average is around 70, there's a huge range, and a lot of research needs to go into what drives the variability in young versus old onset, and what that means for the rate of change of the illness and how you might respond to different treatments, because any treatment for frontotemporal dementia was given in the context of the rest of your physical and mental health. So whatever age of onset, though, FTD has far-reaching consequences. Dr. Thompson mentioned already that around 30% of what's called autosomal dominant, that means a gene that is very likely to show up if you inherit that gene. So, it also has a very high burden, and so within 3 years of the diagnosis, around half of patients will no longer be living independently. It has an enormous cost. The average cost in the US is $120,000 per person per year. I find it more difficult to get an accurate UK figure, but it's probably similar if one adds up both the direct healthcare costs, social care costs, loss of income from carers, husbands and wives, and so on. So it is a very high burden, but more important than the financial burden is the immense stress that this illness can put on other family members. To recap the diagnosis, though, and it is relevant when we think about who will be coming into research and what will the research be on, the diagnosis really rests on a conversation with the patient and the family, looking for aspects of behaviour and personality that really stand out as being, not normal behaviours. It's not the same as just being, a bit grumpy after a bad day at work or a bit rude to a neighbour. These problems that patients may exhibit are really stand out. That will be backed up by some simple tests and examination, and then the role of brain scanning, particularly it should be MRI. This is not available in all parts of the UK, but really one should opt for an MRI where possible. And there's some special tests, including genetics and other things that I'll come on to later. So as we heard in the clip that Sean's played, when asked, how's your understanding, how's your comprehension? The very revealing answer is, what's that? What is comprehension? And some other very simple bedside tests can reveal the deficit of understanding. So I often get my patients to draw an animal. Here a person was asked to draw a horse and a cat and a bird, and it's a perfectly plausible general animal, but what each of these has lost is the distinctive features. What makes a cat, a horse, and a bird even a bird? The bird is an animal, but it lacks all the birdness, if you like. Well, this patient asked to draw a duck, began with an animal, but then got sort of caught up in the legs and got very wrapped up in leg after leg after leg, in a way that portrayed the perhaps sort of enthusiasm and repetitiveness that can happen with the illness. And just again to show this in another example, it's not about the quality of the drawing, it's about what the drawing reveals around the thinking and knowledge behind it. So a cat here shows a perfectly plausible four-legged animal with a tail, but it's too similar to the dog. So it's actually rather too similar to a duck, although this probably has wings. And the elephant is at least bigger, but it's just the same as a big cat or big dog. And this reveals much of the loss of this general knowledge. There's no trunk on the elephant, no tusks, there's no teeth or whiskers on the cat and the dog, and so on. So those are very simple tests. And we then back that up by an MRI. And to just show you here an example of an MRI, this is a sideways view, so the nose and lips at the front, then the main sort of skull and brain vault here, and inside we have the brain, which is folded up. All these folds in light grey are the folds of the brain, and these black streaks here, they're slithers of fluid that tuck in between the folds of the brain and cushion and stabilise the brain. And I've just drawn a line here artificially to highlight the difference between the front and the back of the brain. And as is in the name of frontotemporal dementia, what we see is changes particularly in the front. This is a person with behavioural variant, so for the BV, behavioural variant. And I hope you can see that in the front half of the brain, the fleshy folds of the brain have got thinner, and these black gaps of fluid have expanded to fill the space. So very, very shrunken at the front part, but essentially normal at the back. So this frontotemporal shrinkage distinguishes it from other forms of dementia. This is a clinical hospital type scan. I'll come on to some research applications of scanning it in a moment. But one of the reasons I think it's really important to take time over the diagnostic process, and it is a process, not just a sort of single test, is on the way is to understand what is actually troubling the patient, the person with the illness, what are the particular problems faced by the family, and what might be some of the risks that neither patient or family knows about or is aware of, but you as a doctor might see ahead. And the reason for that is there are many, many aspects of the illness that are treatable that you should aspire to help and treat or have help with in being treated if you're being affected by this in your family. So many, many aspects of the illness. I've listed just some of those here. I won't go through the full list. It's more just to emphasize that there's a lot that is available now for treatment. Many of these could also be improved through further research, better ways to treat each of these types of symptoms. But there is treatment available, and you should be pushing for and asking for treatment where possible. But I'm going to come on now to genetics, partly because it's so important for the clinical aspect, but it's really the gateway into some of the most exciting research and the potential to get even perhaps a cure for some of the particular types of frontotemporal dementia where the genes are at play. It's going to be quite a complex next few slides, so buckle up. It's a bit of a roller coaster, that's what I want to say. But I want to talk you through and explain why it's so challenging, but also so exciting. The first reason is, as Dr. Thompson alluded to, there are many genes that can cause frontotemporal dementia. I've listed sort of the top half dozen here, but there are many other genes, some common, some rare, that can cause frontotemporal dementia. And that's first level of complexity. The second is that these genes can cause different types of pathology. And by pathology, I mean what we see under the microscope. Showing here a junk protein called tau. I think the questions before mentioned amyloid. Tau is another junk protein. And this here has a particular pattern, if you can see it with particular microscopic sort of microscope techniques. But there are many different types, different cells, different types of junk protein. So that's the second level of complexity. What's a real killer for research, though, is that for any one of those types of pathology, there are multiple ways it might show up in a real person, those clinical types of FTD. In other words, with different symptoms. And just one gene can have many, many consequences. So a gene like the C9orf gene can cause one of two different types of pathology, but then an explosion in the type of symptoms or signs that a person with it might show. Called physical things of coordination and balance and speech, changes in personality and behavior, loss of either spoken language or of understood language, and indeed muscle wasting, autoimmune disease type problems. So this creates real difficulty if we're a traditional way of running clinical trials, where you might take someone with one set of symptoms, one diagnosis, and treat with one well-known outcome measure for one underlying cause. And this sort of methodology, this way of thinking about clinical trials doesn't work for FTD. We need a new approach. And that approach needs a lot of collaboration. And one of the most exciting things, I think, from the FTD world over the last decade is to see a real sort of change, a step change in the way that all teams and all parts of the world and all countries are collaborating in order to share experience and share knowledge, to understand how FTD is so variable, why that happens, and how we're going to treat it at an individual level. So the spirit of cooperation, I think, is more than I see in any other branch of medicine and neuroscience. The FTD community is very well aligned, and this is critical to the progress that has been achieved and is moving quickly. And one of the organisations for this is called the Frontotemporal Dementia Prevention Initiative, and it's really in the label. The aspiration is to not only treat frontotemporal dementia after symptoms develop, but to actually get in early and prevent it. So treatments that might slow the illness down, because you can in principle identify many people with it before symptoms. If you were to treat at that stage, you may be able to delay or prevent it. So the first wave of this initiative involves mostly Western countries, but I should highlight that both in the Far East and Southeast Asia, there are research groups who are gearing up to join this global initiative. And so it will hopefully be truly worldwide, led by a tremendous team, just highlighting some of the key players here, and with due thanks to them for the slides that are going to come up. Someone mentioned really around the variety of different genes and the complexity around the world in the questions before, and this chart has come out of this global initiative just to show across different countries how the different common genes are different in different parts of the world. So each of the circles represents a different country, and each of the three colours represents how common it is that a different type of gene will be causing frontotemporal dementia. So don't get too bogged down in the details, apart from perhaps from noting this is a global effort, and also that the results vary. That different genes have different importance in different parts of the world. So if we develop a treatment in one country, we need to be very thoughtful about also looking and developing treatments in other countries. The UK has led one of these component initiatives called Genphy, the Genetic FTD Initiative, led from UCL by a colleague called John Rowe. And the sites in here are represented on the map here, which has recruited 1,200 people from families where there is genetic frontotemporal dementia. Approximately a third have the illness, have symptoms, a third have no gene and no symptoms, and a third are in a middle group where they're carrying a gene but are currently well, which allows us to study the nature of the illness and how it's developing throughout life and how we might get new clinical trials to prevent the illness. So I'm going to show the next three slides, three examples of what can be achieved and some of the insights that have come from this research. The first is that brain shrinkage can be detected many, many years before symptoms come on. So this is I'm going to show you a graph, a chart, and on the horizontal axis here is time in years. Year 0 being the time when, not when you're born, but when your symptoms develop. Okay? And on the sort of axis going up and down, I'm showing the amount of brain volume compared to normal people for your age. So the horizontal line here is the brain volume that's normal for your age. And the graph here is showing how for multiple parts of the brain, 6 different parts of the brain, we can look at the change in brain volume with respect to healthy people of the same age and seeing it gradually reducing. And in different parts of the brain, it's reducing at different rates. If we would look at a patient who's been diagnosed, perhaps been living with their illness for say 5 to 10 years, it's very easy on an MRI scan. This is a slice of MRI scan, the front of the brain here, the back of the brain, right and left. It's perhaps very easy to see that there's trouble and perhaps a change in this frontal part, that the frontal part of the brain has shrunk back. The natural folds have become really paper thin and lost that fleshiness. That's very easy to spot on an MRI after some years. But the real art has been to use some special forms of MRI and special ways to analyze it, which shows us that there are changes in the brain 10, 12 years before, and in fact for some genes perhaps even 25 years before symptoms show up. And it gives a way to say not just that there is changes happening in the brain, but there's a rate of change, there's a decline in underway. It's a dynamic process. What we'd like to know is, could we see if a drug could switch off that decline? So can we go from a rate of decline and to switch it off? And the MRI provides one way we might measure that. Because if you think about the challenge, if you're well, merely at risk of getting an illness, I could treat you now and treat you for 2 or 3 years, and you're still well. So how would I know as a researcher that the drug has switched off the process that is helping you? It's not realistic to treat someone for 40 years and just hope for the best that the researcher will still be around and at a job later on to know if it worked. We have to have ways that can tell us in a short period of time, 1, 2, 3 years, that these new treatments are doing their job to protect the brain and prevent the emerging dementia. We can also look at subtle symptoms and signs of the behavior that might develop early on. And again, this is another plot showing on the horizontal axis time, onset time being year 0. And notice the timescale, really looking back -10, 20, 30, even 40 years. And we're looking at very subtle changes here in behavior that gradually increase as people get older. That's people with no mutation, some of these subtle changes gradually rising. But in people who are carrying the genes, who feel well in work, raising their families, feeling well, we can, if we look, measure some subtle changes. Those changes emerging 10 or in some cases even 20 years before the symptoms begin. So I've talked about brain, I've talked about behavior, now let's think about blood. There are also discoveries now about things we can measure in the blood that can detect the presence of frontotemporal dementia illness. So again, looking over the lifespan here of someone's age. On the right-hand end, what's marked in this red line is CDR1. This means someone who's got definite symptoms, probably living independently, mild but definite dementia. And this blood level in the purple line here shows the level of this chemical called NFL. The names are very forgettable, but it's called NFL, which is increased. It was also increased 5 to 10 years before when they had very mild symptoms. Thinking back to Dr. Thompson's case with a 58-year-old man who, with hindsight, had problems 3 or 4 or 5 years before the diagnosis. But what we see also is it begins to rise, this NFL begins to rise when someone is what's called CDR0, that is completely well. They believe they're well, there's nothing to see, nothing to find, no tests are abnormal in the usual diagnostic sense, and yet already this blood marker is beginning to rise. So changes in the brain and behavior and blood, these are all clear for some years before symptoms. And this can be quite uncomfortable. I think when people first realize this, it can feel a bit unsettling. But there's some very positive aspects to it. The first is that it highlights just how resilient the brain is. That those people with the changes in blood and brain and behavior 10, 20 years before, they felt well. Even though the research tools can detect the illness, they feel well. Their brains are tolerating a certain amount of this disease. And that's extremely encouraging. We can perhaps maximize that tolerance so that people can live fuller and normal lives. It also creates a window of opportunity. If we know the illness is present in the body 10 or 20 years before, that gives a chance to get in and treat it before symptoms turn up, what we term prevention, for want of a better word. And each of those measures of blood and behavior and on the brain test scans, they actually give some really important tools so that people with clinical trials in mind, with a drug that they want to test, they now know, how could I measure it? How could I show that my drug is doing its job? How can I show that a preventative drug is working? Given that you'll be well when I start and you'll be well when I finish treatment, I have to have something extra to know whether I'm helping to switch off the illness. So these new measures that are being developed and validated from projects like Genphy and the FPI initiative are proving very important. So in the last few minutes, I want to just touch on how this is leading to what I'm calling a line of sight to cure and prevention. It's not a reality yet, but each of these mechanisms I'm going to talk about in the next few minutes are coming into clinical trials, or indeed in clinical trials in humans. So I mentioned some of the companies down below. I have no particular affiliation with any of the companies, merely to say that there are many, many companies joining forces with the academic and healthcare community, bringing trials into clinic, into reality. The first way of thinking about it is to say, if the faulty genes are making abnormal chemicals, typically abnormal proteins, that then go off to do damage in the brain, you can now have little bits of anti-DNA, it's called sort of designer anti-DNA, that's synthetically made, very short sections, that latch on to the faulty gene and essentially neutralize it. They're called antisense oligonucleotides. So these are in licensed for some other illnesses, already in NHS use for some other illnesses, and for the frontotemporal dementia, they're now coming into clinical trials. Those abnormal chemicals, the toxic proteins, can spread throughout the brain and cause havoc for the cells that try and maintain our thinking and memory and behavior. So one can also design antibodies. They're called monoclonal antibodies, a very purified designer antibody that's synthetically made, developed in Cambridge in the 70s as a method, but really exploding into medical care in the last 5 years. And these designer antibodies can intercept those harmful proteins as they spread through the brain. Another consequence of the faulty genes is that the normal chemicals that our brain would make to maintain its function, to maintain its own machinery and workings, those normal chemicals aren't made. So some of the ways that are coming to clinical trials now are to use either stem cells or genetically modified cells, implanting those, injecting them in a sense, implanting them into the brain so that they can manufacture locally within the brain the missing chemicals. And those are a bit more involved to get into the brain through neurosurgical procedures, but once they're there, then these cells can replace and pump out the chemicals that are missing. And the other consequence is that the chemistry of the brain can be upset. Too much of one chemical, not enough of another. And again, this may be trying to restore this with some designer antibodies to switch on or off different chemicals that are overproduced or underproduced, or indeed more traditional style chemical type drugs, so pharmacology drugs. So these are very, very different ways to deal with the consequences of abnormal genes, but each of them has now come into clinical trials in humans. But these gene-based therapies, they rely on the ability to have genetic diagnosis and genetic testing. And that means we really need, in the UK and further afield, fair and easy access to genetic testing. And that's really a matter for the NHS services to fine-tune and get right. And it also means people who need to have a right to access research into their condition. And that's what organisations like Joint Dementia Research have become so important, and particularly in partnership with Dementias Platform UK. So just to summarise, I talked about the original description by Arnold Pick and that clinical description that still is true today. I commented on how it can be a young onset dementia, but really can occur at any age from 30, 40 up to 90. We talked about some simple tests and then some more involved tests like MRI, that are both the hallmark of a diagnosis, or a key to the diagnosis, but can also be very important for detecting subtle changes in research. One of the both opportunities from rising from genetics is the ability to identify people with genetic risk and get in early with the illness and to try and neutralize the genes. But this genetic complexity is also a major challenge, and it's a challenge that needs a lot of collaboration and coordination and a cultural shift in research, which has been led by organizations such as the Genetic FTD Initiative I've talked about, the Joint Dementia Research for accessing and connecting people with researchers, and the Dementias Platform UK for sharing, or very importantly, sharing the data, sharing the results so that all researchers can have access to it. And the net result is we now have really a half a dozen different approaches in clinical trials to try and treat FTD, and there are many more in the wings that will be coming through. So it's a time of tremendous optimism from the research community. I am aware that each year that goes by can seem just a very long time for those living with and affected by FTD. I'm just highlighting here on the slide some resources if you or your family are affected by FTD. These are 3 particular websites that can be very helpful in the information they provide. But then to finish the talk, I'd just like to thank the superb team I have supporting me at the Cambridge Centre for FTD, and to thank especially my colleagues at the Genphy team in London and John Gallagher and the DEPA UK. And thank you for listening.
Thank you, James. Another fantastic talk, and thank you for the deep dive into the latest research. So we've got about another 10 minutes. So Siân, feel free to turn your camera on again. So we've got quite a few questions. So I'm hopeful we're going to be able to go through them. The first one, James, was whether somebody in their 70s can relax about having an FTD in future. And you sort of answered this. So I guess I want to push the topic a bit further and ask, do we know why there are these genetic mutations that mean that something just switches on at a particular age? Why do they stay silent until the critical age of 64, where you've been perfectly healthy before with the same gene? What do we know why that's happening?
Several things. So one is, for some genes, you can where there is a gene in the family, I should say, and this is only 30% of FTD, for some of those genes, there seems to be a very strong relationship between how old you are when you're at most risk and how old other people were in the family. Actually, for the commoner genes, that isn't true. So the age at which other people in the family became unwell is no guide to when one's own risk starts to increase. There's lots of reasons for that. One of those is perhaps that we, as well as the bad genes that researchers tended to focus on, there were also protective good genes. We know there are some genes that if you like co-inherit them alongside the bad gene, they can be extremely protective. And that's a bit of a roll of the dice as to whether you do get that protective variant gene from one or other parent. So there's some genetic causes of this variation. There may well be lifestyle. We know that, and it's been shown from the Genphy studies, that the level of education that you have in your early life leading up to early adulthood gives some modest but significant protection. So that may give some resilience to the effect of the gene. In the question you said, how is it you might live to 50 and then the illness comes on? Well, what I think I've shown is that the illness underneath can be developing very early on. You may have no symptoms, but there'll be subtle changes in the brain, perhaps even in your teens or in your early 20s. So it may be present in a hidden way, at a very low level and hidden really throughout your life. There is indeed through Genphy an interest in studying children, trying to look back into early childhood to see whether even in those developing years of early childhood, things are entirely normal or not. So there's what we would call a neurodevelopmental aspect to this that is very underexplored.
Great, thank you. And there's a question perhaps to both of you about what can somebody that's concerned about whether they may be having this condition, what are the sort of the telltale signs from your own point of view? What are the sort of things you'd be looking out for, bearing in mind, of course, that FTD is one of those conditions that it affects sort of behaviors that sometimes are difficult to recognize from the first person perspective.
So that's right. So particularly for this behavioral change, ironically, the person with it often feels very well. It's a small silver lining that the person with the illness may not know they're ill, and if they do know they're ill, they may not quite see the nature of it and feel unwell. Different for the family members around them, of course. Where people have language changes that Dr. Thompson mentioned, that's different. Patients are often very aware of their own language difficulty, and that can be extremely frustrating. My general response to what should I do if I'm concerned is don't struggle with that on your own. Come forward, talk to your GP, and if it makes sense to, come forward for a referral to a memory clinic to be thought about and to get advice and get assessed. This isn't something anybody should be trying to, if you like, self-diagnose or worry about. So if you're worried enough to be seriously worried about it, please come forward via your GP in the first instance. There are often other very benign, what I might call ordinary and certainly treatable causes for some of these symptoms. Anxiety and depression and stresses of life and other medical illnesses can mimic FTD in many ways, and those are things that are certainly treatable. But Dr. Thompson, do you want to comment as well on that? What would you recommend?
No, I completely agree with what you said, James. I think the important thing is, if you're concerned, is to go ahead and be assessed. But as you say, there are many other causes, as I think I spoke about, where there are overlap in these symptoms between a number of other different conditions, both primary psychiatric things, conditions that are very treatable. So it's really important to come forward and be assessed if you're concerned.
That's great. And we had a question about what should someone with a first degree history of FTD do, and should they be seeking genetic counselling or genetic testing? So the specific case was Bronwyn was saying that her mother was diagnosed at 85 and passed away with FTD at 95. She's now in her 70s. Should she be getting a genetic test for FTD?
So the easy answer is there's no sense of you should or you ought to get a genetic test. This is a very personal decision. It needs quite a lot of thought and indeed support and counselling before. So there's no sense of which you ought to. If again, where we worry about there being a likely genetic cause is particularly if the illness has emerged very young in the family, or if there are multiple relatives. So don't forget, the majority of FTD still comes as a one-off in a family. That's particularly when it comes late in life, that's even more likely. So that's perhaps something to also bear in mind while thinking about these very difficult issues. I would also, perhaps if it is very much in your mind, is to come forward and to seek advice, either initially through the GP and then on through either an FTD clinic or the genetic clinics to say, is my family history, not just the one person asking a question here, but also the others in the audience, is my family history enough to be worried about or not? Very often it isn't. Okay, very often it isn't. And most FTD is not genetic, just to re-emphasize that. We talk a lot about the genetic aspect because it's given a way in to some of the ways towards treatments and to study the illness before symptoms, but most is not genetic. And if the member of the family had a particular variant such as semantic dementia or the semantic variant, that is almost never genetic. So it does matter a bit what else the member of the family had as their illness and when.
And related to that, there's a question from somebody who feels that they're, or maybe they know that they're heading down the path of FTD. So the question is, what's available currently, or what should they do, if you like, today, if they want to be offered the latest things that may potentially be helpful? What would your advice be, Jim and Sean?
I think so. So if you believe either you or the person in your family has FTD or early FTD, the way to connect through to researchers, I think JDR, Joint Dementia Research, is one of the best routes in, because many researchers are working with JDR to try and connect to patients with different forms of illness, including different types of frontotemporal dementia. And if within that registration, it's known that you have, or it's felt likely that you have a genetic form, you would be likely to come through to the centres that are across the UK taking part in this genetic FTD research. And that Genphy study that I mentioned, that's working very closely with all of the trials, trying to coordinate and maximise the opportunities for people to join trials wherever they're suitable and wherever it's practicable for them to do so. So I think JDR is a good first port of call, or if you're already in the care of an FTD centre, then to ask them to connect you through, if you have a genetic illness, through to the Genphy organisation. You can find it on the web, or I think in the slides I put their email, not the email, the web address, sorry. So it depends a little bit on your exact circumstance, but I think for most people listening in, I would point to the Joint Dementia Research as the first port of call, because that'll be there's many different research studies, not all of which are on genetic illness. And
Alejandro had a question about what steps are currently involved in the diagnosis of FTD and how may things look in the foreseeable future. And Sean, to paraphrase your words, I think you covered, if you like, the mainstay, which is obviously the history. Then we do cognitive testing, imaging, and if needed, genetics. Yeah. But where do you see the field developing in the near future?
What I'd like to see is it no longer takes 5 years from your first symptoms to getting a diagnosis. People are often halfway through their illness before they get the right diagnosis, and actually getting an early and accurate diagnosis is critical to get the right sort of care and support and advice that you need. So trying to get that shortened. I don't know whether, Siân, you want to add to anything there?
Yeah, no, I just to say that there are some in addition to what we use in the clinic right now, which is obviously, as you said, the clinical assessment being very important, but detailed neuropsychology, structural imaging, and sometimes using functional imaging, which is those sort of metabolic scans. There are some promising signs that there may be blood markers. You mentioned there, James, the research that's shown that the NFL, the marker in blood and cerebrospinal fluid, can be shown to increase before symptoms and thereafter. And, you know, this may become a clinical tool that we can use in diagnosis. We're not there yet, but I think that and possibly other biomarkers will come along that will make this pathway more straightforward, potentially.
But even for those tests to work, you have to first of all meet a doctor who says, could this be FTD? There needs to be awareness in the medical community, whether psychiatrist, neurologist, care of the elderly, whoever it might be, who thinks, is this perhaps FTD? Maybe this isn't just depression in someone's 50s, maybe it's FTD. And only then can you actually trigger or order any of these more specialist tests. So the critical first step is awareness and education amongst the medical profession and our colleagues to even think of it in the first place. Because if you don't think of it, it'll never be diagnosed with any kind of fancy test.
So I'm aware that it's 6:40, but I did want to sort of have one parting question for both of you. So what we've learned about this condition is that it affects the same, if you like, area in the brain. It all concerns the frontal and the temporal lobes, and yet it can present so differently. And James, you spoke about this quite a bit, and we learned from Sean that people can present quite differently. What's our understanding of why essentially a condition which affects the same areas can present, you know, in one case with behavioral change, but people's speech is normal. In other cases, the speech is affected, but the speech can be affected either so that people cannot sort of struggle to get the words out, or they don't understand very sort of simple concepts. What's your sort of conceptual sort of understanding of why this happens, why it manifests quite so differently?
I don't know whether, Siân, you want to take that first? Or like, okay. So I think the symptoms you get are really governed by where in the brain the initial sort of focus is. And once this disease process has started, we often don't know quite why it starts in one person at one time point in one bit of the brain, but once it started, it then spreads. And we understand a lot about how and why it spreads. But the area it first begins with will tend to bear the brunt of disease and dominate. And so that follows what I would call the anatomy of cognition, where in the brain is particularly important for language, where is particularly important for personality and social awareness and so on. These are mapped across different parts of the brain. Why different pathologies start in one place? You know, why doesn't FTD start in the back of the brain? It's perhaps to do with some of the genetic variations. Some different nerves and different parts of the brain are programmed to be different. That's why it's a cell that's in thinking, or why it's a cell that's in memory or in language. So there are differences inside the cells in different parts of the brain. There are also genetic variations, you might call it mutations, or genetic variations that crop up during our body's lifetime that occur in different parts of the body, and they may predispose or give vulnerability to a disease in one bit of the brain. So although we all inherit the same genetic code from our parents, actually every bit of our body has some subtle variations on that genetic code, and that may predispose to different types of illness. But there's much to be done to know what's that initial trigger, and I think in most situations we don't know, not yet.
Do you want to add anything, Sean? Fine. Okay. All right. Well, thank you both, and thanks for everyone for staying with us. It's been for me a very exciting hour, and I'm very grateful for our two speakers, Dr. Thompson and Professor Rowe. I hope you enjoyed it as well, and we'll look forward to our next meeting 6 months from now. Feel free to drop us a line if you think that you want us to cover a particular topic within the brain health space. Thank you very much. Bye-bye.
Thank you.